must excuse me for moving from skin, your major interest, to the bone, much far from your expertise. Glucocorticoid-induced osteoporosis is the topic I will discuss because of the importance of this topic. We could see the effect of aging and drugs on this bone. You could compare the normal bone with the osteoporotic bone in the small scale and in the large scale here. WHO considers osteoporosis as the second global healthcare problem. To emphasize on this, a 50-year-old lady has a similar chance of dying from breast cancer than dying from hip fracture. It's a silent disease. Even after the fracture, many of them go undertreated. The normal change of vertebral column could be visualized here. By aging, the vertebral fractures, the compression wedge fractures, leads to kyphosis and loss of height. That's the radiologic aspect of the spine. 1 in 3 women experience osteoporotic fracture during their life. 1 in 5 men do so. Every 3 seconds, a fracture occurs throughout the world. That reason I selected this topic for this session was steroids. Steroids are used a lot, especially in dermatology. The current information about local steroids does not reveal any effect on the bone, but the lack of long-term studies is needed, is seen, and I think if long-term studies are performed, you can observe the effect of local steroids also. Maximum 2 years I have observed the studies in literature, but maybe it would be a good idea to conduct studies in patients who have received local steroids for more than 10 years, like psoriasis patients. Inhalatory steroids are proven to retard growth in children and produce osteoporosis. Coming to the main topic of my speech is the steroids, systemic steroids. You can have 17% fracture after 1 year of glucocorticoid therapy. 30 to 50% of the patients who receive systemic steroids have fractures. You can look at the diagram. The diagram gives us very good information about the natural growth of the bone. The red line is the normal growth of the bone according to the age. We save bone mineral density till 30 to 40 years old, and then we start losing our bone density. Any insult on this pattern will bring the osteoporotic threshold down, and we will be in risk of fractures earlier in the lifetime. The 2 other curves here are about the patient who has been oophorectomy or castrated patient, that you can see the effect. The steroids have similar effects on the bone. The mechanism is mostly decreasing the bone formation by decreasing the osteoblasts and increasing the apoptosis of the osteoblasts. The rapid decline in bone density is observed during the first 3 months, and it peaks at 6 months. After 6 months, a steady state of bone loss will continue. This is to emphasize the timing of the treatment. The most effective time of the treatment is the first 6 months. There is no safe dose for steroids, according to bone loss. Some studies have shown that have not shown any change in bone with low doses, but multi-cohort studies have revealed that even 22.5 milligrams of prednisolone has effect on the bone. The accumulative dose is more important than the daily dose, and we must observe the accumulative dose also. Something interesting and new in literature is that steroids may help bones. In autoimmune diseases, the cytokines released induce bone loss. If we control the cytokines, we can taper the bone loss. Something like patients who have rheumatoid arthritis and they develop osteopenia, just articular osteopenia. The effect of the mechanism of how glucocorticoids increase fracture is not fully understood, but we know that the effect of the risk is independent of the bone mineral density. Maybe the steroids change the quality of the bone. We must study more to understand more about it. Prevention should be performed in patients who are at risk, or we predict they will be at risk during the treatment. The gold standard for testing the bone is dual energy X-ray absorptiometry, or DEXA. It's very good for the monitoring the response also. If we measure the bone density alone is not a good factor to judge. WHO developed a model, and this is the model that is used in all the machines we do perform bone densitometry, is that to compare the bone density with the peak bone mass that is about 30 years old patient, normal population, and comparing the patient with the with the normal population of her or his same age. Since the bone densitometry measurements did not correlate good with the risk of fracture, WHO developed a software named FRAX. It's a trademark software. You can download it, and you can find the iPhone app also. It helps to estimate the fracture risk, the 10-year risk fracture of the patient who has osteoporosis. Awareness is increasing about this major issue, major health problem, but it's suboptimal. I don't know about the dermatology practice, but I think less than 10% of the patients managed in dermatology practice will have bones evaluated before starting the treatments. Bisphosphonates are FDA approved for treating. It's the first line. They are good drugs. They are effective. Alendronate, risodronate, etidronate, and zalindronate are FDA approved. Zalindronate is the only IV intravenous form approved, FDA approved for treatment of glucocorticoid-induced osteoporosis that is very good because it has a very rapid blood level, and the oral forms have a delay in absorption and blood levels. Another drug that helps is the parathyroid hormone. Intermittent administration of parathyroid hormone has a very good effect on bone, and it stimulates the bone formation and tissue and at tissue and cellular levels, and is very effective in treating bone loss and osteoporosis. Calcium and vitamin D is effective. Many studies have shown the effect of calcium and vitamin D, but it's not universal. Not all reports have confirmed this matter, but it's a fact that patient must have adequate vitamin D and calcium intake. The secondary prevention recommendation varies from country to country. In America, the -1 T-score is the threshold, and in Dutch guidelines, -2.5, and in UK, -1.5. Why there's such difference? The reason is we don't have good evidence-based medicine studies, and different countries have different resources for their health issues, and all the guidelines are written to meet their situation. Now coming to the American College of Rheumatology recommendation. I say recommendation because there's no guidelines, there's no strict guidelines for this field. There must be a clinical judgment, and if a patient doesn't have a FRAX has a, if a patient does have FRAX score, you must remember that the FRAX score uses only the average steroid intake. Those who take high doses of steroids will be underestimated with the FRAX evaluation. The recommendation: if patient has no fragility risk, no adequate data for treatment is present, but I actually personally I'm questioning this problem. If we know this patient has to take years of a steroid, and we know that a steroid will harm him, why not starting the treatment from the first place? But we need good clinical evidence-based medicine studies to recommend this generally. If a patient has a childbearing potential, because all the drugs used, the bisphosphonate, are not indicated in pregnancy and in patients who have a desire to be pregnant. There's an issue of recommending them the bisphosphonates. The childbearing potential people, ladies who have to take 1 to 3 months of steroids, there's no consensus for treating them. For women or men women who don't have a potential of pregnancy, or men under 50 years old who take short-term steroids, 1 to 3 months, if they uses low-dose steroids under 5 milligrams, the bisphosphonates, oral bisphosphonates, are enough. And if they want to take more than 5 milligrams, of 7.5 milligrams of steroid, you should consider zoledronic acid, the IV version of bisphosphonates. If the patient needs more than 3 months of a steroid. Adding teriparatide or PTH, parathyroid hormone, will be another option, and or teriparatide. Thank you for your attention. Any questions?
Thank you, sir, for the nice presentation. I have just a question. You have told about the cumulative dose in your presentation. So how much cumulative dose is needed to start osteoporotic, mainly glucocorticoid-induced? How much cumulative dose is needed to start having effect of glucocorticoid-induced osteoporosis? Yes, sir.
I can give you an example. When you have a bad economy and you're going to have a foreclosure, how many money loss would lead to foreclosure? It depends on the reserve of the patient. If a patient has a good reserve, you can give steroids. You don't give any harm to him or her. But if the patient is in the border of a fracture, maybe even a month of prednisolone will lead to fracture. If she or he doesn't take that 1 month of prednisolone, she won't experience a fracture. It's very difficult to answer. It depends on where how much is the reserve of the bone.
Thank you, sir.